I started looking after patients with ovarian cancer in the mid-1970s, and at that time the only drugs that we had were cyclophosphamide, and we were starting to use cisplatin, but the results of treatment were really quite poor. Over the 30 years since then, results have improved, although the fact is that because the disease does present beyond the ovary in the majority of cases, it's not curable in more than a minority. Nevertheless, what we have found is that treatment results have improved as we've introduced more drugs, and importantly, we've got much better at multidisciplinary care. Having said that, the results of conventional chemotherapy have rather reached a plateau. And the exciting thing in the past few years is that we're beginning to see some real impact of completely new molecular targeted treatments, probably the most exciting of which is this thing called the PARP inhibitor. The basis of the use of PARP inhibitors in ovarian cancer is something called tumour synthetic lethality. And what that's to do with is the fact that in the normal process of replication of most cells, single-strand breaks of DNA are formed. Now, these are normally repaired by this enzyme called PARP, but if that's blocked by a PARP inhibitor, these cells form double-strand breaks. Now, that's actually not a problem for most cells because they can easily repair that with a process which is called homologous recombination, HR. Sounds a bit jargony. The thing is that certain cancers, and these are cancers that run in families, the so-called BRCA mutated ovarian and breast cancer, these cancers contain cells that can't repair damage that way, that are so-called deficient in this process called homologous recombination, or HR. And that means that when these cells are treated with a PARP inhibitor, they actually die because they can't repair the damage. And that's a very selective process, which actually doesn't apply to other cells. This turns out, having been tested in the laboratory some years ago, to really work in the clinic, and that's really exciting. I think the future really is that we'll get much better at being much more selective about individual treatment. That is, understanding when we see a patient with ovarian cancer, what it is in that patient's cancer that's made that cancer develop. We will stop treating each patient the same way. And that's because we'll be able to say, this patient does have a cancer that will respond to a PARP inhibitor, this patient has a cancer that will respond to something else. And that's getting better and better.